Hello, good day. I'm Dr. Pourjavan, the glaucoma specialist from Clinique Saint-Luc in Brussels, Belgium. And I would like to share with you our small experience with the endocyclophotocoagulation. So we have done a observational, non-randomized clinical study with only 21 patients, but they are really real data, real-world patients. So, as I told you, it was a non-randomized observational study. So what we did, we just wanted to know if as primary outcome, if the ECP was enough to reduce our IOP, and we wanted to look at the safety, and we wanted to know if we could just diminish the number of the medication for glaucoma. Our patients were a vast group of patients with glaucoma. We had patients with iris plateau, we had patients with closed-angle glaucoma, and we had patients with open-angle glaucoma as well. The problem was that because they were a real data patients, real-world patients, we had patients that they had different history of surgery. So you probably know by now how the ECP is done. So we began first with general anesthesia because we didn't know how much the patient would have pain and would be bothered by the laser. But then we switched, after a couple of patients, we switched to the topical and local anesthesia. And I have to admit that with the local anesthesia and a top-off, the patients didn't have any problems. I tried first, or most of the time, just supratemporally because I was using the curved angle. So it gave me a very good access to 270 degree of treatment. Sometimes I needed to open a little bit more supranasally as well. As you know, at the end of this procedure, so I was trying to do 270. Sometimes there was problems because the patients already had a photocoagulation, so the ciliary body was not really in good health to be again using a ECP. So we have done nearly 270 degree. Very important, we cleaned very thoroughly our anterior chamber, take off all the viscoelastics, and I did intracamerally aprocam, cefuroximes, and intracamerally dexamethasones. I didn't do any subtenon or subconjunctival dexamethasone, but the patients were using steroids 4 times a day as it was needed. In 2 eyes, we combined our phaco with the ECP, but the other eyes, they were only standalone. So this is a very small short video of how I did it. As you see, because it was one of my first one, I probably did more plus D than a total photocoagulation. So I just show you because as you see the tip, I'm just coagulating the tip, but then trying to paint it. So that was probably not a very true photocoagulation. So that's why I'm calling it baby steps, because we were learning. So as you see, as the results, we have the mean of IOP, intraocular pressure before the operation, the number of medication. We have a very short follow-up yet. So at the first day and as the weekday and first month, the pressure was lower. As you can see, it was significant, and the number of medication was just a little bit lower. Now, first of all, we wanted to see if it was working and if it was safe. So we were not really focusing on decreasing the number of topical medication, which we will do in the next randomized studies. So as I told you, the decrease in IOP, even in this heterogeneous group, was significant. The number of the medication was not significant before and after. So as you see the statistic, we have the last one. The last one, it is the last time that we saw the patients, but from the 21st patients, we only saw 9 patients now. So as you see, the pressure is significantly lower. Hopefully I will have the 21 patients for the last IOP measurements, and then we have the right results. So as adverse events, we were very concerned by inflammation because as I told you, our patients were patients who had multiple operations. So I was a little bit afraid of having inflammation, and that's why I didn't do a truly 360-degree of photocoagulation. So we had rare cells in week 1 in 11 eyes, which were treated normally with the topical steroids. And after 1 month, they were only a little bit mild inflammation in 2 eyes. The inflammation went away after 12 months. I had 2 cystoid macular edema, and there were no need for injection. We used only Diamox and NSAIDs. So as I told you, it's a very small group. We are doing baby steps. There is a short follow-up. Hopefully we are going to organize now that we know how we should do. And I was learning the procedure. Even though that's a small learning curve, we need to see if a plus is enough for some patients, or should we go a true, should we do a painting and be more aggressive of doing, instead of 270 degrees, 360 degrees. We had patients with juvenile glaucoma, aphakic, patients who had iris plateau, so patients who have been operated a couple of times. But the good thing is this just real world data. So we took the patients, we thought they needed ACP, so we have done ACP. The good thing about ACP is that you can combine it with other operation, with phaco, and you can use, for instance, a trabecular bypass or other mix or lasers. So it gives you the opportunity to do that. And I think that for the patients that I've done only 270, because I'm doing that from the anterior chamber, there's possibility to do it again if needed more thoroughly. This was our results. I would like to thank the group of BVI in Belgium, which I have been growing up with them, and they always gave us the opportunity to use the new technology. Thank you.